placement or IO line placement. So on the left, we have all the supplies that are going to come in your kit, both the different needle options, the gun, the IV tubing, and the dressing. And then the right is a completed IO line setup. So with IOs, so with IVs, we're shooting for a vein intravascular. So we're going into a small kind of finite area. Within the center of the bone, we actually have a big vascular network. So the bone marrow is actually very vascular, and that's what we're shooting for. And you can kind of see from that photo up on the top right, kind of on that cross section, we have a pretty big target what we're shooting for. So what you guys normally do, kind of very finite, you have a very small target. Shooting for bone marrow, we have a much bigger target, much higher risk for success. Now there's complications that go along with it, which we'll go through, but in general, this is a kind of an easy target that we're gonna go through. So we have 3 different needle sizes. So standard for adults is going to be blue. Pink on the left side, the shorter needle is pink pediatrics. And then on the right side, yellow is the larger needle. And with that, think yellow adipose tissue. We're going through something bigger to get through it. You can see on each of the needles, you have those little black lines. Those are 5 millimeters apart. And we'll kind of go through using those to kind of measure which one we're going to use. But in general, pink is going to be kind of 3 to 39 kilograms. Blue is going to be 3 kilograms to kind of adult size. And yellow is going to be our fluffier adults, or if we're going for a thicker area. And we'll talk about the different areas with IOs that we're going to be able to aim for with this. So in general, the reason I went over the black lines is the technique that we're going to use, we're going to advance through the skin before we even start drilling, and then when we hit bone, that's when we'll engage the drill. So when we advance through the skin, we want at least one black line showing here and here. Now there's one black line above the skin. If this, before we even pop through bone, we don't see any black lines showing, then even if we go to drill, high odds that that IO is going to back itself out, even if we do get through the marrow, but a possibility that we won't actually have enough needle to get through the marrow. So kind of a good depth gauge with that there. Now that being said, you can use the longer needles if you have kind of a bigger target that we're shooting for. So you can have more than one black line exposed, but in general, about one black line exposed is a good kind of target that, hey, now we have 5 millimeters, that's enough to get through the outer layer of the bone and into the marrow. So the general technique that we're going to do, like I was saying, we're going to kind of first advance just through the skin. So the needles are pretty sharp, they will be able to actually push through the skin, and then you'll hit bone. So you'll hit some resistance. Once you've actually hit bone, then you'll actually engage the drill component. And that's going to give you that little bit of force, that little bit of drilling power just to pop through the cortex. And you'll feel a physical pop. So we'll do some hands-on here so we can get the tactile feel for everything. So this is just kind of step-by-step, row 1 and then row 2 for placing IOs. So first thing we're going to do is identify our landmarks. So this is a pediatric patient. So tibia on a peds patient is going to be a pretty easy go-to, mostly because the landmarks are easy to find. So what we're going to do is go to the patella up here. We're going to go 1 centimeter, about 1 finger breadth down, and 1 centimeter towards the inside of the shin. And if you feel on your own shin, there's kind of that big flat area. So you have a pretty big target to shoot for. Then similar to setting up an IV, we're going to clean and prep the area. And then we're going to go through step 1 and step 2 like we did on the last page. We're going to advance through the skin and then drill till we feel that pop through the cortex and into the marrow. Then, once we have that through the skin, we know we're popped into the right place. The way that this gun comes off the needle is it's just magnetic. You just slide it straight off. So you'll stabilize your IO line and you'll just pop the gun off. The next step after that is all of these have a center stylet in the middle of the needle. I'll put it on this one. So what we'll do is unscrew there, and that stylet slides out, and now we can actually infuse. This actual needle is solid bore, so we can't infuse to that. So we need to take this off before we can actually start infusing or doing anything of that nature. Once that's screwed off, we make sure we help secure this to the skin, and we put our dressing, which come with the kits, on top to secure it into place, and then we can set up the line similar to normal. Now, as far as picking site location, there's different kind of risks and benefits to each of them, but generally on adults we have 6 sites, so 3 sites on each side, but we have 2 sides, and on pediatrics we actually have 8 total sites. On adults, our main go-to is going to be the proximal humerus. The main reason why it accepts fluids a little bit faster, flushes and draws quite a bit easier. That being said, when we get our traumatic patients or our cardiac arrest patients, proximal tibia is going to be a really best and easy go-to because you're away from where everyone's doing compressions and doing all the other interventions. You can easily set up a line, start doing a blood draw, and start infusions and epi pushes from there. And then distal tibia is a far less used option, but still, just because of dogma, it's still a very good option that we can be able to use. The only additional thing that we have on pediatric patients is we can use the distal femur. On adult patients, there's just too much muscle and too much quadricep tendon usually to get through into that area, but on peds it's not quite as much tissue, so we can get line access on there. Main reason that I bring all of this up is because usually we'll try an IO. If we can't get it, we'll say the IO failed. We can't get an IO. Even on an adult, you have 5 other options to try. On a kid, you literally have 7 other options to try. So don't have an issue with trying to place, trying to go for another site if one does happen to fail. Now, as far as since we talked about the humerus and that being the main go-to on adults, once again, we're kind of finding our landmarks before we go. So if everyone wants to kind of feel on their shoulder, we feel that ball kind of there on the front of your shoulder. Put your hand across your belly, and we'll feel this ball right here. That's your greater tuberosity of the humerus, okay? And so that is gonna be our main target. It should feel like a little golf ball on a tee. The main way that we're gonna feel for that on a patient is we're gonna do kind of the karate chop method. So we're gonna put one hand with a karate chop here in the crease of the armpit. The other hand is gonna go on the outside lateral part of the shoulder, and then we're gonna bring our thumbs over. And you should be able to, at that point, palpate that little golf ball site. And then that's the site that we're gonna shoot for on them. Now, we wanna get the arm appropriately positioned. Most of the time, for all of us, we're just gonna be able to put the arm across the belly. But if we have a pregnant patient with a gravid abdomen, or one of our fluffier patients, that's still gonna turn their arm all the way out here. It's gonna be hard to aim for. If that's the case, you bring their arm down, and you just turn their thumb down backwards, and then you can line it up the same as normal. Only tricky part with the humerus placement is we don't want to drill in at a 90-degree angle like this. It just doesn't infuse quite as easily. If we angle it just at a 45-degree, it infuses straight down the marrow of the bone into the humerus, and it flushes and draws quite a bit easier for us. So that's the only tricky part that's a little bit different than the tibia and the other sites. So that's for the humerus. For proximal tibia and distal tibia, those are kind of our 2 other sites on an adult. So for proximal tibia, the main way that we're going to kind of feel for it is if we go on to our patient, we'll feel, everyone can feel on themselves that little bump right here below your knee on the top of your shin bone. That's called your tibial tuberosity. So that's a good landmark. Usually you can feel it even on our fluffier patients. You are going to go 2 centimeters or just 2 finger breaths to the inside, and then either straight across or 1 centimeter down. And usually you'll have this big flat area right there on your shin bone to be able to aim for. So you have a pretty good big target. Like I said, most of the time you guys are shooting for these little tiny veins. This is a little bit more caveman. You have a much bigger target to shoot for. In addition, on our distal tibia, we'll feel the end of our ankle bone there. And we're just gonna go about 3 finger breaths, just proximal up for it. And that way we kind of know, once again, you'll feel right there, that big kind of flat area on the inside of your ankle bone there. And for these, we're just gonna go 90-degree straight into the bone. So a little bit more straightforward. Now, so for kids, distal tibia is gonna be about the same, just not quite as far down. So it's just gonna be 1 or 2 finger breaths instead of 3. So you just don't have to go quite as far up the shin. But once again, on kids, we have proximal femur as an option too. And so the main way that we're gonna feel for this is we're gonna feel their kneecap. We're gonna go just above it, just about 1 to 2 finger breaths. And we're gonna go just medial, just about one finger breath. And the main thing is you're just kind of shooting just to the side of their quadriceps tendon. That way if they start kicking or screaming, it doesn't disengage the IO. All right, so contraindications to IO. Funny pictures, kind of over the top examples, but just good general concepts. So these are when we wouldn't place an IO on a limb. If there's a fracture at that site, 1, it disrupts all of your landmarks. 2, you're gonna go into an open fracture and it's just gonna go into the soft tissue. Most of the time, unless they're kind of a polytrauma, you're gonna have a lot of other options to be able to pick from. Just pick another one. 2, this photo up here. So if they have significant orthopedic procedures at that site, we don't know if there's hardware under there. We don't know if there's prosthetic bone under there. So ideally, we'll have to pick a different kind of location because, hey, we don't even know if we'll actually be able to get in the marrow. We might hit metal, prostheses, something like that. So this would be a patient you'd pick distal tibia or go up towards the shoulder. Of course, if there's infection at the site, this wouldn't be something you would start an IV on. Same thing, you wouldn't start an IO on it. You're just going to introduce infection into the bloodstream. If we have significant tissue damage, so this big open wound here, even if you can pick the landmarks, it's not really something that's going to be able to secure. One, it's just, hey, don't do that. Two, there's not tissue that's going to hold it in place. So pick a different limb. And then finally, if there's just a lack of anatomical landmarks, these are patients we're going to get where they have pretty significant pitting edema, they have other anatomical issues going on. Most of the time, oddly enough, on these patients, even if they're incredibly fluffy, their shoulders are not going to be as fluffy as the rest of their body. So these patients, even if we can't get anything else, sometimes we can go up and get a humerus IO and get some sort of line secured. All right, so what medicines are compatible with IOs? Nearly everything, really. The only additional kind of caveat is because it's not directly into the vasculature, because it's just this big system of vasculature, it doesn't draw and it doesn't flush as easy. So if it's a pediatric patient, you're doing push-pull fluids. If it's an adult patient, you're doing pressurized bag fluids. You can't just let it hang to gravity, it just won't ever flow in. You do have to put some effort into it. Similarly with your draws, when you're drawing back fluid and blood out of it, you are gonna have to pull a little bit harder. It's not a vein, so it's not gonna collapse in the process. You don't have that to worry about, but it is something you do have to sit there and hold the plunger back. It won't be kind of a finesse draw. Now, IV contrast is compatible with these. So if we get a trauma patient, we get an IO secured, we can push IV contrast. The only additional caveat with that is we want to take this IV tubing off of it because it kind of messes up the timing with it. So when they get them back to CT, you go back with them, and before they go to hook up the contrast, just take this part off and they'll hook up the contrast tubing directly to the IO. Now, the annoying thing with these, well, oddly enough, this is not very painful at all to push through the skin. We had one just a couple days ago, and she didn't care at all when we drilled through the skin, didn't care at all when we popped through the bone, pinched like a bee sting. But when you do start to infuse through it, that's the painful part. So if the patient is conscious, if they're coming in as a code, a trauma, they can't really respond, don't worry about anesthesia to the site. But if they're a conscious patient and they're just kind of pericoding, they're heading downhill and we do this IO, then we do want to do some anesthesia into the site. I'll go through kind of how we do the lidocaine, how much of it to do, but before we start doing any kind of infusing or even a flush, we'll want to do some lidocaine into it so it doesn't burn like heck when we go to do the infusion. So a little bit of a busy slide, but the main thing kind of wanted to show is when we do lidocaine in here, on an adult, it's going to be about 40 milligrams. On a kid, it's 0.5 mg per kg. And we're going to give it slow. We're going to give it over about 2 minutes. Now, the easiest way to kind of remember it is most of our lidocaine is going to come in little 2% lidocaine vials. If we do 2 cc's of that, that's going to be about the equivalent on an adult. Now on a kid, we're going to have to measure it out a little bit more, but on an adult, if you draw up 2 cc's of 2% lidocaine, you infuse it over 2 minutes, that's usually able to get good anesthesia. If that still doesn't work, you go to flush and it still hurts like heck, do it again a second of time. And then usually after the second time, they'll be nice and numb after that, and you'll be able to do the rest of your fluids, the rest of your medications. So easy way to remember for the lidocaine is 2 of 2 for 2 times 2. So 2 cc's of 2% infused over 2 minutes, and you can try it 2 times. And that's a lot easier to remember. And then with a kid, same thing, just measure out whatever 0.5 mg per kg is going to be. All right, so what labs are good, what labs aren't good that we can draw for them? So your H&H is going to be appropriate, your glucose is going to be appropriate, all your kidney function is going to be appropriate, and then this is all for British websites, so Group and Save is type and screen, so your blood type and screen is going to be normal. Now the things that aren't going to be appropriate, your platelets, your white blood cells, and annoyingly, your sodium, potassium, and bicarb. All those just aren't the same in our marrow as they are in a vein, so those won't be very useful. But some of your important things, like I said, your type and screen, your blood count, and your kidney function is all going to be appropriate. Now, these basically are annoyingly not going to be appropriate, so if we have a code or pericode, we're just going to have to assume, hey, are they hyper K, and kind of go from there. The only other annoying thing is some of our iStat machines aren't going to be able to handle it. In my past experience, our ones here handle it just fine, but I've read articles on some of the iStat machines, the blood is too thick and it kind of breaks them. So just apologize to respiratory if that happens, you know. But my experience, it's been fine here for us. So the reason I'm doing this big push kind of for IOs, and I want us to get this training of it, is they are a great temporizing measure. They're not great for long term. Ideally for long term care, we want IV access or central line access, but they're a fantastic temporizing measure. And what I mean by that is we can get an IO quickly set up, we can get fluids into somebody enough that their veins plump up, and then we can get an easy or an appropriate IV access attempt, as opposed to somebody that's just dry, they're in septic shock, they're hypovolemic, or they're bleeding out, and we just, doesn't matter how many times we poke them, that vein's just gonna keep collapsing. So these, really what their purpose is hey, we get fluids, we get some sort of product into this person enough that we can then get an IV access. So even if it's a kid that's tanking, we get a couple push-pulls of fluid into them, now we have a good IV to shoot for instead of every single thing is collapsed on them. And especially in our patients that are coming in as bad traumas or as codes, hey, we have an access that we can give epi pushes through, we can give fluids through while somebody's working on an arm to get an IV, okay? Part of the other reason I wanted to push for these is there's been a big kind of hesitancy with them, understandably, simply because we don't do a lot of them, that they're incredibly painful, they're a traumatic mechanism, and they aren't until they're a Hail Mary, their last ditch effort. Main reason I want us getting some hands-on time here is I want everyone to see they're not quite as painful as we think, they're really not that traumatic, and they shouldn't be a Hail Mary. They should be a, hey, medium Mary, okay? Of, hey, ideally we're gonna try to get some IV access, and we're gonna do a couple good attempts at it, and then if the patient's getting sicker or we're concerned that they're heading downhill, hey, let's really quickly drill an IO, it's not a big deal. We'll get their veins kind of plumped back up again with some fluids or whatever the medications we need, and then we actually have an actual IV access attempt that's not gonna be significantly inappropriate or collapse down. So this is a great temporizing measure. Like I said, it's not an end-all be-all, but it gets us to a point where we can have an appropriate and great long-term access. So what we'll do is we got a bunch of models here, we'll get some hands-on time, I want everyone to kind of get the tactile feel of it, both on a humerus, a tibia, and just drilling in general. And then hopefully the next time that we have a patient that we get to this kind